Do it. Hi, I'm Dr. Vizniak, and today we're going to be going through a basic fracture screen. So this will be based on Canadian C-spine rules that are used in the ER with Ottawa variations, Pittsburgh rules, you name it. We're looking at an amalgamation of all these different types of assessment tools that you can use to help figure out if there's a fracture. The first and most important thing, like any assessment that we do, is getting a detailed history and then progressing through your exam after that. So, Kaylee, welcome to the clinic. How are you doing today?
Good, thanks.
All right. So tell us what happened.
I was doing pull-ups and I had my legs out in front and the bar failed and I fell to the ground.
Okay. So you were doing a pull-up and you fell down, so you were actually up into the doorway basically?
Yeah, I was pretty much at the top.
Okay. How did you actually hit the ground, if you can remember it?
So the bar failed, and as I was coming down, because my feet were out in front, I thought I was going to hit my head. So I don't know if I grabbed the bar with my right hand, but I landed on my left wrist, my tailbone, and my right elbow.
All right, so what we have here is a history of significant trauma. If she was older than 55, likelihood of fracture also goes up, but definitely history of significant trauma. She's falling from roughly 6 feet to 7 feet high, flat onto the ground, with her feet straight out in front of her. So you know that that's a hard landing. The next thing you would do after your brief history, at the very start, is you'd watch the patient walk in and look for a 4-step test. Now we know this for the lower extremity as a way to assess for fracture. Is can the person take 4 normal steps? A failed 4-step test for the lower extremity typically looks like a limp, where the person walks and they do a quick hop over top like this. It also applies for other regions of the body. If she had a spinal fracture, I would see her walking with a very soft gait. So she would step with her toes first and walk very rigid. If you asked her to turn around, she would spin very, very slowly and very controlled through the body. For an upper extremity fracture, why don't you just go ahead and start right here and just walk towards me. This is how a patient presents with an upper extremity fracture right here. So we'll go ahead and have you sit down right there. You'd look through and say, do we see any bruising or swelling in the area? And the easiest way to do this is for her to hold her hands up for the second camera, and you can look right away, and it's pretty obvious to see this dark green bruising all the way up and down her forearm here, and nothing on the contralateral side. So you do that bilateral comparison, you can see right away the difference. Yeah, and if she flips in again, you can see it all the way around. So now the question is, what specifically is going on, and how far can I actually challenge this before I decide I need x-rays or further follow-up? So our basic starting point right here would be, can you go ahead and point to the area of most tenderness that you have?
Right in here.
Yeah, so she's pointing kind of to the distal or lateral side of the radius right here. What I would like to do is go ahead and do a hands-on assessment. The most important thing you need to do in cases like this is do not push on the injured area first. The most important thing is to develop trust with the patient, check the unaffected side first. So if we can actually we can just stay where you are. I'll go ahead and just palpate this. What I want to do is get a baseline for normal. I'm palpating with my hands, but I'm also looking at her for any reactions as well. If she has any pain or discomfort, looking for the tissue tonicity and any point tenderness that she might have in there. Everything feels pretty normal, good motion, can take the wrist back and forth and move it from side to side. The next thing that we're going to do is move on to this side. I'm not going to start at that area. If it's painful or uncomfortable, let me know right away, and if you feel like it's too much, you can tell me to stop right away. Okay. Crucially important that you give the power back to the patient when you do this portion of the exam. So from here, I'm just going to start right there. The other thing you'll notice is I'm looking at her as much as I am palpating and looking at where I'm palpating. Just looking for any kind of wincing or any kind of signs of pain or discomfort. Working down the radius and ulna, I can feel right off the bat that the tissue does have a lot more fluid into it. That tells me that there was more interstitial fluid or even blood into the space. I'm just going to squeeze through like this down the distal ulna. Everything's okay?
Yeah.
Yeah. So we stay nice and light into the metacarpals all the way through, coming across like this, and then I'll work my way back into this region.
That hurts.
So right there we have maximum tenderness, and that's a light pinch. Yeah. I can actually feel a fairly good pulse there on the radial pulse. That would be good enough for me right now to actually think x-rays are warranted, but the next thing I could do is a resisted isometric test. So starting from here, if I can, I'll just have this hand down. Can you push into my hand with your hand? And you don't want to push very hard. That's pretty light right there. Let's just go ahead and do it to the other side for comparison. Go ahead and push hard. Yeah, and she's got really good strength there. And the same thing this way. Can you push into my hand? All right. The fact that she doesn't want to generate torsional forces across that wrist also shows me there's an increased likelihood of the framework being damaged, which means a bony fracture. The next thing you can do from here is check range of motion if you think that there's minimal displacement or there's no chance of laceration of vessels or nerves. So from here, we'll get both of your hands out as much as you can do, and then bring them up as far as you can. And right away, significant difference from side to side, and we'll go ahead and extend all the way back. All right, and fairly limited there as well. And again, you can see the bruising on this side compared to the opposite side. High likelihood of fracture when you're looking at a patient like this. If you want, you can turn a tuning fork onto this right here. So if we take a tuning fork, I'll apply it to the unaffected side first, just so you can see what it feels like. So we strike, and you just place it over bony prominences, and you can feel that vibration. And how does that feel?
It's fine.
Yeah, just feels like a vibration?
Yeah.
Yeah, all right. Okay, and we're going to go ahead and repeat on this side. So I'll push right there.
It's fine.
Totally fine? Yep. Up into here. Okay, I'm going to go over top of the radius. If it's too much, let me know. But
yeah, I can feel it. It's like a little bit of a buzz in there, but it's not painful.
All right.
I can feel it more.
So that's an important thing for us to get. So this is a tuning fork on what I suspect is a fracture. Actually, it really is. We have it confirmed on X-ray, and we'll put those up here in a second for you to look at. But the tuning fork comes back negative. So many doctors and therapists think that when I put a tuning fork on a fracture, it's going to light the person up. I've had experience 1 week, I can remember in particular in practice, where I saw 3 hand fractures. The tuning fork was only positive once. All right, so this is a good one for you to toss in there as part of your bag of tricks to help diagnose if there's a fracture. But if it comes back negative, we can see this. There is a fracture on this radius, but it doesn't alter your pain perception at all. Mm-hmm. All right. Point. So if you're worried about neurologic compromise as well, you could go ahead and check dermatomes if you wanted, or median, radial, and ulnar nerve cutaneous distribution. Or if I wanted to, I could actually check her grip strength, which would simply be, she'll put her hands at her side. Can you go ahead and just squeeze my fingers here? Okay, not so hard there, Hercules. All right. But then we'll go ahead and repeat on this side. Go ahead and squeeze as hard as you can. And the force is literally about 10% of what it is on her. Are you right-handed or left-handed?
Right.
She's right-handed, so I'd expect it to be stronger, but it was substantially weaker, again signifying that there is disruption of the osseous structure that those muscles need to pull on. Okay, thank you so much for doing this. It's so fantastic that you broke your wrist for us like this. Okay,
awesome.
So many people are going to learn from this. It's actually really excellent. So, and I know it's going to heal really well. So the treatment for this basically has been, of course, X-ray to follow up, but then it's also going to see if there was displacement or if the fracture went through the joint cavity itself and into the cartilage, and then you might need an orthopedic surgeon consultation. But this is going to be a relatively simple case with just a simple splint, that you can take off. She's protecting the area but trying not to damage it any further. So, okay, this will be a good healer for you.
Yeah.
All right. Okay. High five. Okay. Other side.
No way.
Okay. All right. Okay. Thank you so much.